Happy Friday night. Welcome. You guys will all be muted when you come in. We're going to keep sound off, just to kind of make it clear for everyone. Feel free to leave your cameras on or whatever you're comfortable with. But who you're hearing is Erin. We'll kind of jump in, introducing ourselves and then starting our presentation. So I'm Erin. I am a registered dietitian. I have my master's in nutrition as well. And I am the founder of the Celiac Space. I've had celiac for over 10 years now. And at Celiac Space, we're a team of dietitians, and we work with celiacs, non-celiacs on a variety of different health issues. So that's kind of what we do, as well as just providing resources and whatnot for clients. So we are also joined by Dr. Dankner, and I'll let her introduce herself for us.
Thank you. I'm so excited to be joining you, Erin, and the Celiac Space. Thank you so much for inviting me to speak with you today about this really important topic. So I am Lauren Dankner. I am a board-certified pediatric gastroenterologist. I work at the Valley Hospital in New Jersey and Mount Sinai Hospital in New York. I primarily see pediatric patients, but I really see infant through young adults. And I had a lot of experience with the diagnosis of celiac disease, managing after diagnosis, and sort of leveling risk among family members. So we have a lot to speak to you guys about tonight.
Yeah. Awesome. So we'll get started with the presentation. Lauren, if you see anyone jump in the waiting room while I'm talking, just let them in.
Okay.
Okay. Let me get my screen set up real quick here. Okay. All right. So we have introduced ourselves. If we got lost on the screen, I'm Erin at the top, Lauren, Dr. Dankner is at the bottom.
Thank you. So really, I wanted to sort of clarify what the talk is for first. So many people go gluten-free because they feel better and they have gluten sensitivity. But this talk is really specifically for celiac patients, and it's important to distinguish because the intestinal changes are very different in celiac disease, and understanding kind of the physiology and the mechanism of the disease, sort of briefly, not to bore anyone, but that can help us sort of understand why it takes time for someone to feel better after going gluten-free. So this is really for celiac patients specifically. Next slide, please.
Yeah.
So everyone wants to know, obviously at diagnosis, how long should it take to feel any change really in your symptoms? So understanding kind of the amount of inflammation and damage in your intestine is important. And that's why it's so crucial that you really, and most importantly, have an accurate diagnosis. So lots of people sort of just assume the diagnosis or do some, over-the-counter swab or gene test. And it's really crucial that you are diagnosed by a physician, and typically requiring an endoscopy. And that's really how you can verify this is true celiac disease, because it is a lifelong change. And on endoscopy, you can see these changes under the microscope. You see villus damage, which are those projections into the small intestine. You see different amount of inflammation depending on the person, and they're scoring for sort of varied degrees of inflammation and damage. It doesn't really matter if you have sort of the moderate or severe. It doesn't sort of make so much of a difference in terms of making the diagnosis. It's really most of the time a yes or a no. But it may sort of change the way that you're responding and the timing. So how long it may take really depends on, the person, and everybody's different, and the way they're introducing their diet is very different. So imagine you are diagnosed with celiac, you're ingesting gluten, it's inflammation in your intestine, those villi projections are now blunted and they have to regenerate. So this can take several days for different cells to regenerate, but for full small bowel healing, it can take up to a year or even longer. I would say that most people feel better much before that. So even within a few days of going gluten-free, you should feel something. Most of the time, within a week, I would say you typically see a change. I do meet some patients who really have not many symptoms at diagnosis, other than, this was detected just on screening because my mom has it, or, growth failure and they didn't really feel any symptoms. So sometimes, it's a little bit harder to convince someone that they need the strict gluten-free diet, but really, that's really the only treatment at this point. So depending on what is going on in your diet, your specific symptoms, how strict you are with cross-contamination, which we'll talk about, it may depend sort of on all those factors about how quickly you will see results, but I would hope within a couple of weeks, things should be much improved. And then within a few months to a year, you should be really feeling well. So this talk will be sort of outlining some of the other reasons why you may not be feeling great after being gluten-free. Next slide. So the sort of normal symptoms of celiac disease. So you may have been diagnosed because you had bloating or diarrhea or constipation or belly distension, hair loss, rashes, headaches, whatever it is, growth failure. All of these things on a strict gluten-free diet really should go away. So those symptoms should be better if you've given enough time really for your body to heal and for the inflammation to go away. So it's not like, you have a food allergy and you remove the allergen, or you have lactose intolerance and you remove the milk and immediately within a day you feel better. It's really a process, and your body is working on feeling better. But I would say you shouldn't expect symptoms related to the really the underlying disease if you're following the diet. So it's not a disease that should cause really further implications of nutritional factors or infertility or even the gastric cancers if it's really properly managed. It's when there is, contamination, or someone decides they don't want to follow a gluten-free diet for whatever reason, that we do worry that, you're at risk. Obviously, ongoing inflammation is not good for the body. There's been some new studies that you may be at risk for coronary artery disease and, infertility and the gastric cancers and all that terrible yucky stuff. So going strictly gluten-free and reducing that inflammation is so crucial, and much of that risk is then brought closer to the baseline. Next slide, please.
Awesome. So like she mentioned, with celiac, part of the reason it's important for us to have this conversation is I get all the time in my practice when we're working with celiac clients is, well, I have celiac, so of course my bowel movements are funky. Oh, I have celiac, so of course, I have bloating or I have headaches. And when we look at their diet and when we work with them, we determine, but you're gluten-free, you've been gluten-free, you've allowed enough time for your villi to heal, for inflammation to decrease. So really there shouldn't be symptoms. And so I think it's important for people to understand with celiac, when properly managed, it should be a pretty symptom-free condition, disease, obviously with the exception of if you do get gluten, which happens, or, if there's still gluten sneaking in on ways you're not aware of. So we're going to talk about symptoms, what we would expect to be normal and what is abnormal, because there's a lot of misinformation of what you should expect, right? What we would like to see when we're both seeing patients and clients in clinic. What are we looking for and what are we assessing? So bowel movements are my favorite marker. They're one of the many markers, but they tell us a lot of information on a client. And normal bowel movements. So over here, we have our Bristol stool chart, 1 through 7. What we would like to see is a 3 and a 4. So that's like ours. See the pictures, right? We've seen those in the toilet. What we don't want is 1 to 2, 5 to 6. It's a spectrum. It's important to understand not every bowel movement is going to be a perfect 3 or a perfect 4. We aren't robots. We don't eat the same things every day. So there is going to be some variance. However, we want to see most of our bowel movements meeting these normal criteria, which is 1 to 2 easy to pass bowel movements a day. So you're not straining, you're not in the bathroom for an extended period of time. Most bowel movements are the 3 and the 4, right here, kind of on this chart. The other thing that I think is important is the feeling of completeness after a bowel movement. It's a little graphic to talk about, but I know we've all had bowel movements, and there's a difference between having one where you feel like that was a good one, that did the job, and other ones where you sit there and you're like, do I still need to go? That doesn't feel right. Something's off. So that feeling of completeness is another good marker. And then your ability to control the bowel movements. So not having significant urgency is another important factor. So that's really what we're looking at for normal bowel movements. I would say in my practice, what I see most people are struggling with are having enough. So they're not having 1 to 2 easy ones a day, or their bowel movement consistency is a little funky. Everybody will have a different baseline. I think that's kind of important for us to keep in mind too, but this is kind of what we're looking for and taking into consideration. Also, we'll be doing a Q&A at the end, so if you guys have questions, you can drop them in the chat if it just pops into your mind. Feel free to add that in there. So on a similar flip side, I guess, talking about abnormal bowel movements. So what are we not looking for? What do we not necessarily want to see in the toilet or have us feel? So 1 to 2 up here, these are our constipation. Constipation isn't necessarily just having not enough bowel movements. It can also be the consistency or the feeling of an incomplete bowel movement. So that's what we categorize constipation is fewer than 3 bowel movements a week. I would certainly like to see more than that, or the straining or feeling of incomplete, as well as these kind of consistencies. So it's all those factors. I found that a lot of times with people, they think of constipation just as frequency when there's a little bit more to it. Diarrhea, also abnormal. That's our other end of it. That's 5, 6, and 7. Again, it's a spectrum from completely watery stool to more pulp-like to more pieces. And that would be over 3 times a day if we're having that, as well as urgency. Another thing for us to keep in mind that would be considered abnormal is that the stool has like a mucousy to it. It has a film. We get a film left over in the toilet if it's black or contains blood that we can see. Those are other things that we want to keep in mind. So understanding the difference for bowel movements, what we should expect, what would be abnormal, can help us better understand what could be going on.
So bloating and distension is something that I get a lot in my clinic, celiac or not. But really, anyone is going to have some degree of kind of mild bloating or may have some mild bloating after eating. And that's totally normal. And that's just what happens with sort of the digestion and the passage of food. Normal distension is some amount of gas moving through, and your belly might actually look a little bit more full at the end of the day. But when it becomes really more of an issue is painful bloating. So the feeling of being really full or uncomfortable after you've had a meal or sort of throughout the day. And abnormal distension is if you remain distended and it's not going away with passing gas or with passing a bowel movement. Some of these factors may indicate other things, which we'll talk about. So whether it's sort of nerve hypersensitivity, something related to irritable bowel syndrome, lactose intolerance, all of these things are, things that we would ask for both on the dietitian end and the gastro side. So it's important to sort of just take note of what is the difference between a normal and abnormal sort of change in that gut throughout the day.
Yep.
Other symptoms really should be minimal for celiac patients. So this is, again, assuming that you've been 6 to 12 months gluten-free, giving your body enough time to heal and sort of get rid of this inflammation by reducing the gluten stimulus to the immune system. So anyone can experience some burping and gas or symptoms of reflux or pain here and there or fatigue. It doesn't necessarily mean that it's coming from your celiac disease, right? So it should go away if you're, following the diet and not being sort of inadvertently contaminated. But fatigue could be from many other factors. There's other diseases and disorders that we'll talk about. Pain can be, I would say, sporadic in anyone, celiac or not. So I wouldn't necessarily blame these symptoms on either, let's say, being contaminated or someone not following a strict gluten-free diet, because these things can be intermittent and sporadic really for anyone.
Yep. So we're going to get into some common mistakes that people make when going gluten-free. And this is important because it can help us determine, are we truly gluten-free? Which, when we're working with clients in our practice, and they come to us, they're celiac or, on a gluten-free diet, we want to make sure that, are they truly being gluten-free? If they are, then if they're having these other symptoms, we can begin to look at other things. We can do gastro referrals and be monitoring other factors. So I want to cover, kind of what some common mistakes are, so that we can dot our I's, cross our T's, make sure we are following a gluten-free diet. So first one is not paying attention to cross-contact. Cross-contact, you may also heard of as cross-contamination. Same thing, cross-contact is a technical term. It occurs when a gluten-free food touches a not gluten-free food. So this has the potential to transfer gluten from the gluten-free or the gluten-containing food to the gluten-free food, which could make it no longer celiac safe. There does have to be a significant, contact, and, there's high touch areas or like risk factors of this. For example, at a restaurant, something like a shared fryer. So if you were to get French fries, potatoes, and oil are gluten-free, but if they're frying chicken nuggets, which are breaded in that fryer, and there's a lot of the extra breadcrumbs and stuff in there, the chance of your French fries getting enough of those breadcrumbs to be a concern is problematic, right? So cross-contact is, I guess, a little bit of a gray, like there's not hard, fast rules for it. It's somewhat of a case-by-case basis. And a lot of information online contains a ton of fear-mongering around this. So while it's important to understand that cross-contact is a very important thing to be aware of, and we need to do everything within reason to be mindful of it and to avoid it, there is information online that have people going overboard. And we have clients that have come to us who have gone gluten-free, they don't feel good, and so they assume, well, I must be getting cross-contact somewhere. And so they go more gluten-free and more gluten-free and more gluten-free. And then I get the questions of, does my tampon need to be gluten-free? Does my nail polish need to be gluten-free? If you're asking yourself those, we've probably gone too far and we're missing something, whether it's a very simple part of cross-contact or another health factor. So important to keep in mind, there is a line with cross-contact. Doing too much avoidance and hypervigilance can also be problematic. So important for us to kind of find a happy balance with that, between staying safe and staying sane. So with cross-contact, if you are throwing caution to the wind, not being mindful of it, frequent cross-contact is what can lead to higher exposures of gluten, which delays healing, causes more damage, more inflammation, that kind of stuff. I also want to point out, just because there is so much fear online, cross-contact, we don't live in a gluten-free bubble. You will in your lifetime, if you have celiac, get glutened. Whether it's your mistake, somebody else's mistake, it happens. So I just want to not necessarily normalize that it's okay to have that happen, but when an accident happens, to give yourself grace and understand that, and really just be able to learn from the experience. Next is missing hidden gluten on food labels. So again, I always clarify the misconception on a food label, gluten will never truly be hidden in the sense that it's in the product, but they don't label it. It will always be on the label. It's just a matter of you know what you're looking for. That's how it's hidden. It's not always clear. It's not gluten as the ingredients. So we use what I've created is the no and woe ingredients. I have a ton of resources on my website of how to read labels, as well as cards like this that are like physical copies that you guys can order. And it's a comprehensive list of what gluten would be. A no ingredient is something that always contains gluten, barley, bulgur, couscous, rye, etc. A woe ingredient is what people more think of as the hidden ingredients. So brown rice syrup, dextrin, modified food starch, etc. Those are the ingredients that can be from gluten or can be gluten-free. So you have to do a little bit more digging on that. I won't get fully into the details on how to read a label. There's a lot more information that we have on our site, but that's one important factor is people are not understanding what they're looking for. Another good source of hidden gluten is vitamins and supplements. So gummy vitamins is one. Children's supplements like oral suspension and drinks is another one. Over-the-counter supplements that are not regulated properly, or like powders and green juices and that kind of stuff, are common. Not as common in prescription medications, but still present. So all things that you do need to be checking for. These are no and woe cards. Again, they're on their website, as well as a full label reading guide for the ins and outs of certified gluten-free labels. What does a gluten-free claim mean? All the different factors. So definitely a great resource.
Can I ask you, Erin, for the woe cards?
Yeah.
What do you suggest to your patients, like smoke flavor and natural flavoring, sort of all these vague things? How do they know really what is in it?
Yeah. So the easiest rule is if you pick up a product and it has a woe ingredient, if it has a gluten-free label, it's safe. So if you pick up a product and it says natural flavoring, but it says gluten-free, you're fine. That gluten-free claim tells us that the woe ingredient is from a gluten-free source. If it doesn't say anything, that's when it gets trickier. And when you either skip the product or you look on the company website and see if they have any statements. So unfortunately, woes are not my favorite. They make it tricky because they're not as clear, and you sometimes need to do a little bit more digging on a company website. But if a product has a gluten-free label, like it says gluten-free on the package anywhere, even if it has a woe ingredient, it would be safe. Another common question, also we cover this in our label guide, but not following our celiac safe oat rules. So there's two. If a product has oats in it, let me backtrack. Oats are naturally gluten-free, right? So oats are one of our gluten-free grains. However, because of processing, there's a high risk of cross contact in the fields, in the production lines, all along the way. Because of that high risk of cross contact, in order for oats, like oatmeal, or any product that has oats in it, granola, cereal, cookies, whatever, if it has oats in it, we need to take extra precautions. And so we have two rules for a product with oats to be celiac safe. It either needs to be a certified gluten-free product, which is our gold standard of testing to ensure it's celiac safe, or it needs to say gluten-free oats on the package or the ingredients. One or the other, doesn't have to have both. Some products won't, just for the sake of space and marketing on the package, but it needs to have either a certified gluten-free label or state gluten-free oats. So big offenders of this Cheerios, Lucky Charms, Nature Valley. A lot of those products contain oats that are not necessarily celiac safe. So understanding this is an important factor.
And there was a huge issue with Cheerios claiming to be gluten-free. And I usually say for the first year to just try to limit or avoid Cheerios for this reason. I don't know what you recommend to your clients, but there's definitely in batch testing inconsistent amounts of gluten, and that's why they sort of got a little bit in trouble by the celiac community. So again, just for the Cheerios, I would say you don't need to avoid all oats in the first.
Right, not all oats. Cheerios specifically. What makes it tricky is they're sponsored by the Celiac Foundation, and so it says celiac on the side, which is very confusing. However, it's not a certified gluten-free label, and they don't use gluten-free oats. I recall I was in college and I was so excited. Cheerios was always my favorite. I didn't eat them. And then they found out they were all going to be gluten-free. I bought a box, I got very sick. And then they recalled it, and they've had multiple recalls since then. So because of that, they just can't get their act together. Cheerios, Lucky Charms is the same, two brands that I don't recommend. Another one is not asking the right questions when dining out. So dining out is one of the trickiest parts of celiac in terms of knowing what to ask, the social aspect, the taboo of asking questions. When newly diagnosed, it's like a foreign language almost to like be able to communicate and ask these things. I will say from experience personally and with clients, it gets easier over time. I kind of tell people it's like when you first had to recite the Pledge of Allegiance, you had to like read it off a chart and like, you know, fully understand what you were saying. And now you just like right hand over your heart, blah, 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 which is basically how I communicate with servers now. It's just second nature of what questions I ask, what I'm looking for, that kind of thing. So the goal is to get everybody there. But initially, or if you've been gluten-free for a while and have been avoiding eating out, not understanding how to do it properly. So a few things to keep in mind is a gluten-free menu is not always celiac safe. While I am very grateful that more companies have gluten-free menus, it's gluten-free by ingredient, not by celiac standards. They're not keeping into account cross-contact or the oat rules. So that's kind of something for us to keep in mind when we're asking questions and ordering. A gluten-free menu is a good place to start, but I wouldn't order from a gluten-free menu blindly. Meaning I wouldn't see the gluten-free menu and say they have gluten-free pasta, great, I'll have gluten-free pasta, and never say anything else, right? So it's important, you know, for something like pasta, where they could be, and many restaurants do, boil their pasta and gluten-free pasta in the same container with a separator. The water being shared is an issue alone, not to mention noodles jumping ship. So that's something where on the gluten-free menu, they're going to say, we have gluten-free noodles. Is it celiac safe? No. And so understanding that you need to ask, is it made in a shared pot? Do you have a separate colander? Are you sharing the same marinara label? Those kind of things. So that's important to keep in mind. Other hotspots include a shared fryer, which I've discussed, shared dips and condiments, a shared grill. So in like, for example, in small, you go to a cafe and they have gluten-free pancakes on the menu. Are the pancakes grilled on the same griddle right next to the regular pancakes? They're being flipped with the same spatula. There's a little, you know, squirting and flying of flour going on. We want to be avoiding those things. Shared toasters, also a concern. They might have gluten-free toast. How are they toasting it for your sandwich? And then I guess we can kind of consider a general rule is gluten-free alternatives cooked with gluten containing items. So like I mentioned, the pasta is our gluten-free alternative cooked with the standard item. We have, as I mentioned, we have our label guide on our website. but we also have a dining guide. So those are kind of our two staple resources. The dining guide contains all the questions you need to be asking, examples of scripts. If you go to a Mexican restaurant and you want tacos, what questions you need to ask. If you go to a Chinese restaurant and you want stir fry, what questions you need to ask. So that's another great resource that I know Dr. Dankner offers for her patients and has used a lot. So that is something that is available on our website as well for you guys to check out. Another common mistake is just eating a ton of processed gluten-free foods at diagnosis. I see this a lot when people go gluten-free, and understandably, they want to try, if it says gluten-free, they want to try it. I know many of us have been there. If it says gluten-free, I will buy it. Let me buy it in every flavor and test it out, which means that your diet becomes a lot more processed. And so a few issues with that is rice products. A lot of the products are more rice-based, can be more constipating. So that can be a symptom factor. And a lot of these processed foods have refined sugars, so the fiber isn't as high. They're higher in sugar, which can change bowel movements and whatnot. So really being mindful of how much your diet is changing when going gluten-free. A lot of people assume if you go gluten-free, you eat healthier, which would be nice, but not always the case, right? Not everyone gets healthier when they go gluten-free. So being mindful of how are you changing your diet and how might that be changing symptoms alone. So another important thing for us to keep in mind.
So I'll talk a little bit about some underlying health conditions. And I guess the first thing that I want to bring to light is, as the physician, my personal obsession when I meet someone who's been diagnosed with celiac, of really being very certain that you do have celiac disease, especially if you're not following the typical course and if you're still having symptoms and really being strictly gluten-free. Everyone should be monitored yearly, whether you're a child or an adult, for nutritional deficiencies and your celiac serologies and your blood work. So you should be meeting with your doctor anyway, a gastroenterologist, and someone should be knowledgeable. And if things aren't going right, sort of questioning if things could have been different from step one, from that diagnosis. So there are other things that do mimic celiac disease. So even if you had an endoscopy and things were questionable or it looked like celiac, there's tropical sprue and, infections and inflammatory bowel disease that can either be confused with and mimic celiac disease, or it can coexist with it, right? So you could have celiac disease and something else. Unfortunately, having celiac disease, which is an autoimmune disorder, does put you at risk for a lot of other autoimmune disorders. So those could be also giving you symptoms. And these are, things that you need to be screening for really routinely, because, thyroid disease and iron deficiency, these things can be quite sneaky. So it's important to sort of understand your personal risk, your first degree family's risk. So if someone, either your parents or a sibling, was diagnosed with celiac, or your child, you should also be screened, right? So the risk is definitely higher. We talk about first degree relatives another time, but really general population risk being about 1%, and depending on someone's genetics, 3 to 8% typically for a first degree relative. So it doesn't mean that you're definitely going to get it, but you would be more at risk compared with someone else. So the common sort of coexisting condition that I see that we'll talk about separately is lactose intolerance. We'll talk about that in a bit. Refractory celiac disease is incredibly rare, and we don't want anyone to think that, if you're still having symptoms after a year, that you have refractory celiac disease, that, your condition is not going to get better on a gluten-free diet. It's very rare. We just wanted you to be aware of it. And then the other underlying GI conditions or other disorders, I will talk about those as well in detail. Thank you. So lactose intolerance, I want to say I see this in nearly all of my celiac patients at diagnosis, and you can truly test for this by taking an extra biopsy at diagnosis and sending it for a separate enzyme test. But basically, lactose is a sugar that is broken down by the enzyme that's on those tips of the villi in the small intestine. So when the damage is done in celiac disease and you're missing those villi and they're shortened and blunted, you have damage and missing enzymes at the top. So it can be just lactose intolerance, but you can be deficient in some other enzymes. There's sucrose and maltose and isomaltose and some of these kind of funky other enzymes that you probably don't worry about or ever sort of hear of, but they do come up on this testing and on the panel that is sometimes sent, sometimes not. But I would say for anyone who is suspicious, especially early on, when you're not healed in the early months, that they may be lactose intolerant, even though studies show about maybe 50 or so % sort of coexisting with celiac. I see it all the time. And if you do eat lactose, and you do get sick from it, I would say don't worry that it's causing more damage. That's just going to give you symptoms. So the ongoing gluten exposure is what's going to cause the inflammation. If you have lactose intolerance, meaning if you have enzyme deficiency, often this is transient, and it will typically get better, I would say, in the majority of people. But if you have suspicion that you're lactose intolerant and you didn't have that special biopsy or test, there's a few things you can do. One, there's a special breath test that you can talk to your doctor about. So basically you drink a lactose containing suspension and then you breathe into tubes and they send you back a report of what gases you're producing in the gut. So that's one way to sort of formally diagnose it. Honestly, it's usually not covered by insurance. And I tell my patients, I like to keep things sort of manageable and easy. And you have enough going on, I would say either eliminate dairy and see if you feel better, or try like the lactate pills or the enzymes at the start of a dairy meal or snack. And that's really just giving you those enzymes that are missing for the lactose at least. So again, this is very common. I would say try it. And if it makes a dramatic difference, then that's your answer. It's definitely trickier for the other, what we call disaccharidases. So the other enzymes, they're found in a number of foods. And I would say maltase, the enzyme that breaks down maltose, I mean, that's present in most of the gluten-containing foods, which you're going to be eliminating anyway. So I would say practically this is the one that might just make the most sense of either reducing or treating with that specific lactate pill or lactate milk, which is just the enzyme in the milk. Everyone thinks it's lactose free, which they market it as, and it's not. They're just adding a crushed lactate pill into the milk. So really, I would say just to make things easier, if you think dairy is bothering you, it's very common. And that's one thing to try if you're feeling bloated or having diarrhea. Next slide. So again, this refractory celiac, again, just bringing it to your attention. This is persistent or recurrent symptoms and true damage if you had a repeat endoscopy after 6 months to 2 years, I would say, on a very strict gluten-free diet. And the majority of cases that have been sort of reported for refractory celiacs are really just people who are not following a strict gluten-free diet. And it doesn't mean going to the end of the earth of only eating home-cooked foods that are strict gluten-free. Obviously, Erin, you're not limiting yourself to the bubble of your home cooking, but to the level that we sort of think is reasonable for a patient with celiac disease. So these underlying conditions. So again, these can be a primary issue or these can be coexisting. I would say irritable bowel syndrome is very, very common, and especially sort of noticing that certain foods may be bothersome, and so many things go into IBS and what we call visceral hypersensitivity, and sort of under this umbrella term of disorders of the brain-gut interaction. So there's many different sort of psychological, manifestations and underpinnings of this, but I would say irritable bowel syndrome can definitely mimic celiac symptoms. And if you think that you're being contaminated, or if you're having sort of these ongoing similar symptoms, it's important to ask your doctor about IBS. So there's irritable bowel syndrome, either diarrhea predominant, constipation predominant, mixed, and a lot of foods can trigger, these symptoms. Obviously not specifically gluten, but whether it's eating spicy foods or greasy foods or dairy, it can cause bloating and diarrhea and constipation and all of that. So I would say IBS, very common. SIBO is something that I feel like a lot of people hear about, and I don't know, maybe there is some overdiagnosis, but it is a legitimate condition. It stands for small intestine bacterial overgrowth. A lot of people are suspicious about it, and I would say it's really important to not overdiagnose for this, right? Because the treatment initially is an antibiotic. Obviously, diet changes and sort of modifications to the lifestyle, but really antibiotics should be given when it's a breath test proven SIBO. So it's really an imbalance and a dysregulation in the gut microbiome, which are all those bacteria and yeast and fun things that live in the normal gut that are definitely altered and changed in someone with celiac disease, like other disorders. And it can also be more common in someone who has changes in the movement of the gut, which we call gut motility. So definitely you can be at higher risk for SIBO. SIBO is usually something that's going to cause visual distension, really bad bloating, diarrhea. You can have fatigue. So that is something that I would definitely ask your physician about that. Inflammatory bowel disease, that is something very near and dear to my heart that I have had extensive training in and research in. And I would say if there's any ongoing, what we call red flag symptoms after your diagnosis, you should be skeptical in very certain circumstances. So inflammatory bowel disease encompasses mainly Crohn's disease and ulcerative colitis. Ulcerative colitis typically more obvious in symptoms of having frequent diarrhea or bloody diarrhea. Crohn's disease can be much more sneaky, and it can present in many different ways. But I would say if there's really ongoing severe pain, or in children, if they're still not growing, or if the diarrhea or joint pain or things that just aren't fully making sense, or if you've had blood work and the inflammation numbers are abnormal, that's when I would be sort of searching a little bit more along the IBD pathway. And not to say that many people with celiac disease or anyone on this call will have IBD or develop IBD, but again, being another autoimmune disorder, it's important to sort of think about it. And, if things are not going as planned, to just keep that on the back burner. Thyroid disorders. So you really should be screened for autoimmune thyroid disorders. So I see a ton of coexisting Hashimoto's, which really is a thyroid condition that is seen with pretty high prevalence in the celiac population. And really any other immune condition, you can have autoimmune liver disease. So all of these things, if something else is going on that is making you not feel right, if you're unusually fatigued or weight changes or jaundice or, nausea or vomiting, these are things that should be brought to your doctor's attention. Infection, anyone can get an infection, and there's a billion of them that I won't be talking about, but whether it's gastroenteritis or a parasite, who knows? Obviously, we need to take into context the history and the travel and the exposures. But I do I do often speak with celiac patients who think they've been glutened, and I always wonder, like, is this just a stomach bug that your friend had? You'll never know, probably, but you know, you're a normal person too, and you can also have other things that other people get, right? So just like reflux, I mean, you can get reflux, and I would say it shouldn't be associated with celiac. Psychosocial factors, so especially in the kind of earlier stages of diagnosis, there can be a ton of anxiety, and specifically social anxiety. How do you eat out of the house? How do you go out to dinner or explain to a partner that you're gluten-free? So really, it can be a very stressful time, and that's why it's really important to have appropriate resources. So you need your physician following you. You need to be routinely meeting with a dietitian. So that's why, you know, I think the Celiac Space is so cool, because you really provide these fantastic resources for patients so that they do feel confident going into a restaurant and going out to eat with their friends like a normal person, right? Because this disease shouldn't define you.
Mm-hmm.
Next slide, please.
So I guess one thing I wanted to comment on this slide was all of these things can be treated, right, Dr. Dankner?
Yes,
we can address them. So
yeah.
I say that it sounds obvious, but a lot of people think that this is normal and think that they just have to live with IBS and SIBO and IBD and reflux. And, you know, while there are some conditions like IBD that you mentioned is a tricky one to treat for sure. And each patient is different. These are things that you should just be dealing with without any support. So what do you see most in your practice?
Me?
Yeah.
Non-specific belly pain, I would say, is the most.
Yeah, I'm sure a lot of people on the call are like, me too.
Yeah.
So, sharing a little bit more about what we do at the Celiac Space. This is me and my team of dietitians, all celiac. We work with our clients one-on-one to kind of give them more support on the diet side of things, and kind of managing a lot of what happens in the gut is directly diet related, right? So things like lactose and dairy and elimination diets can all be managed through diet, which is what a dietitian does. So if going through this, either you were like, I'm making some gluten-free mistakes, I could use a little bit of support, or I've done all those things, I feel like I have gluten-free down and I need more support. Our total wellness program is how we work with our one-on-one clients. And you'll get an email follow-up about this, but for the first time ever, really, because I know so many people need support, we're offering a discounted rate for our services. So if you feel like you have questions or need more support, please reach out to us and we can kind of discuss. We're a network with a few major insurance companies. So those are things to keep in mind. I always like to share what resources we have, because too many people are struggling finding the correct resources. So if this is something that sounds like you, my email is open. You'll also be getting an email tomorrow morning with a recording of this video, this PDF. So keep an eye out for that. And with that, I'm going to stop sharing my screen and we will do some Q&A.
This is my favorite part. I'm so excited.
We have some good ones. So one question was, will we be sharing the recording? Like I said, yes, we will. You'll get the recording in the morning with the PDF. Send it to whoever needs to hear our voices. Yeah, it's a great resource. I'll jump from one for Thomas, and then I'll let Dr. Dankner, you can jump in on some. Okay. So one question is, most restaurants will not guarantee celiac safe because cooks might accidentally cross contact. Yes, 1000%. If you were to come to my house, which is 95% gluten-free, my husband has cereal and I don't know what else he snacks on, but I would not bet my life on it, my dog's life, that you would not get sick. Right? The reason is we don't live in a gluten-free bubble. I would do everything I can, right? I would consider myself a professional at cooking, right? But no restaurant, when they have a liability, is going to guarantee that they can keep somebody celiac safe. It's very, very rare. Even restaurants that are 100% gluten-free, it's a liability. So if you're at a restaurant and you're asking all these questions, you're ordering off gluten-free menu, you're really comfortable and confident with it, right? And they say, oh, but you have celiac and we can't guarantee it's gluten-free. Depending on how they're wording it and how confident you are in the questions and the conversation, don't let that be something that turns you away from always eating out, right? There are plenty of safe restaurants where you can order a safe meal from that aren't going to say, oh, we promise you it'll be celiac safe, because that's a very tall order. So that's just kind of something to keep in mind and to not necessarily shy away from. With cross contact, I say it's not something to be scared of, more something to be aware of. So keep that in mind.
Just going through the questions here. So a lot of people are asking, where do we find doctors who know how to do this and test for this? I'm sorry, I understand that not every doctor is a good listener, and I would say an expert in this. If you do have access, depending on where you live, I would say to a gastroenterologist, that's where I would start. Obviously, I mean, there's a few celiac centers, in the country. You don't need a celiac expert per se. I would say any board certified gastroenterologist should be able to help make the diagnosis. If access is an issue and you live somewhere rural, your primary care doctor really should be able to send the initial testing. So screening needs to be done on a gluten containing diet. So you really need to be eating at least the equivalent of 2 slices of bread a day, for whatever that's worth. You could substitute it for a muffin or pasta or whatever, for 6 to 8 weeks. And then you can ask them for the celiac screen. If they do not know what that involves, often they send the entire gigantic panel of antibodies, many of which are not very sensitive or specific and sort of confuse the picture even to us. The initial screening should be 2 orders in your blood work. One is the TTG IgA, tissue transglutaminase IgA antibody. That is the most sensitive and specific screening test. However, because it is an IgA antibody, you need to be IgA sufficient. And there is a very high rate of IgA deficiency with celiac disease. So if you happen to be one of those unlucky people that gets a really low IgA, typically below 30, and a negative TTG, you may need to do more testing. And at that point, I would say see a gastroenterologist. But those are the first screening tests. So if you have enough IgA and your TTG is negative, it is very unlikely that you have celiac disease. The gene testing comes up a lot, and I see someone was asking about first degree relatives and what do you check for? The first degree relatives should be also screened with the same TTG IgA and total IgA. You can check for the genes. So there's certain genetic markers, certain genes called DQ2 and DQ8 that are part of the celiac gene panel. And these genes are present in about 40% of the general population. So they're also linked with other autoimmune disorders and diabetes and thyroid disease, and that's why they're all kind of so common. But it's necessary for the development of celiac disease, but it's not sufficient in itself. So if someone only checked your celiac genes and they were positive, it does not mean that you have celiac disease. It means that you could in your lifetime develop celiac disease. And there's different levels of risk based on which combination, and it gets very complicated, and that's not important. But I would say for someone who has maybe a questionable diagnosis, so you've met with your doctor, you had a scope, it's a little borderline, your blood work's borderline, we don't know. Sometimes at that point, we'll send the gene. And if your genes are negative, you do not have celiac disease. And even if you get a borderline test on your TTG, so normal is like 3 and under on most labs. If you get like a 4 or a 5, and it's super borderline, and you kind of don't want to do the endoscopy yet, if you get a negative gene on the gene test, if you have 0 DQ2 and DQ8, virtually you should not develop celiac disease in your lifetime. It would be incredibly, incredibly rare. So for first degree relatives, I typically recommend TTG, IgA, total IgA, and I do send the celiac genetics, because if you get a negative, then you don't have to keep worrying about it, right? If you get a positive, then whatever, you don't keep checking every 6 months, but if at some point in your lifetime you have symptoms, then you can recheck the antibodies at that point.
Yeah. One common question that is touched upon a little bit is a lot of people are concerned that their doctor doesn't understand celiac, or their doctor did the diagnosis, right, and did all that stuff and then said, follow a gluten-free diet. And that was somewhat the extent of the support that they got. I will say, if you're a patient of Dr. Dankner, you'd get more support than that because she is lovely. But explain, I guess, the role for us, a little bit of the difference between the doctor's role and the dietitian role, because I think a lot of people expect the doctor to wear both hats, which is challenging.
So you're asking me, what do I mean,
like where does your line stop?
So I give a lot more time to my patients than most people do. And you need to block out the time for a new diagnosis. I mean, it's not something where you just say, yes, you have celiac, and then I kick you out the door. It's real. I do basic dietary counseling, and I talk about, to a limited degree. I mean, obviously I go over what's in the house, what's in the kitchen, the basics of sort of going gluten-free and looking at labels. I touch on the basics of going out to eat, but I can't go into detail at the level of what you would do. It is in our societal guidelines to see a dietitian at diagnosis. And really, I mean, obviously recommended if someone, would like to thereafter. I mean, that's more than reasonable. But I would say for the detailed level of contamination, I would trust a dietitian to sort of go over that, and sort of get like a food diary and swaps and alternatives for some gluten-free options that would be good for the patient.
Yeah. I think it helps eliminate the frustration that I've heard a lot, and many of you guys may have experienced, of like, my doctor didn't help enough, right? And so I think making sure that you guys have both on your care team, a doctor to get the ball rolling, to get diagnosis, follow-up care for treating other conditions that were mentioned, and then a dietitian for that more nitty-gritty detailed support, as well as, managing other dietary needs.
Can I also just say, though, I love your company because you have celiac disease, right? So I see so many people who are like, can I see a dietitian who has celiac disease? And I'm like, I don't know that many. So that's why I've often referred so many patients to you. It's a different level of understanding and sort of being helpful just in your basic day-to-day dining and living. If you truly have this yourself, I think that's like something very unique to celiac disease and to your company. So
it's interesting because in school, and I was talking to a dietitian about this, she's like, we didn't learn celiac disease in school. And I was like, yeah, I know. Like, people think most dietitians know celiac. If it is taught in school, I promise you, all that is taught is celiac disease is an autoimmune disease. It requires a lifelong gluten-free diet. That's the question and answer on the test. So if you go to a dietitian that isn't specialized in it and doesn't live it, they will be Googling it. They'll be Googling through it, right? Same thing if somebody comes to me and they needed help with renal, kidney support, I can Google my way through it. But am I a specialist? No. So I think that's important too, is understanding not all dietitians are a specialist, and it can be really helpful to have someone that lives it.
A lot of people are asking where to find a good GI doctor. I can't say I can vouch for any of these people, but if you go on the celiac disease, I think the Celiac Disease Foundation website, supposedly there's a list of people, and I can't say whether or not they've truly been screened to be celiac experts or whether they are sort of just members and pay the dues, but that's at least a starting point. And obviously, speaking with people sort of in your community, I'm sure that someone else has celiac disease and, personal referrals.
There's a question on is PCOS an underlying condition as well? So PCOS, polycystic ovarian syndrome, is more hormonal based, not correlated with celiac. Obviously, there are people that have PCOS and celiac, but it is not necessarily that one causes the other. Correlation does not mean causation, so keep that in mind. There are a lot of conditions where two people have them. That doesn't mean it is celiac related. For example, you'll see if you guys are in Facebook groups, one of my pet peeves is, and this is an extreme example, but someone might type or ask, I get a lot of paper cuts. Does anyone else get paper cuts? And then you have 1,000 celiacs reply, I get paper cuts too. And so then people assume, oh, celiac and paper cuts must go together. They have nothing to do with each other, but you only ask celiacs, right? So keep that in mind. People with celiac have other conditions too.
Lauren asked, is a blood test sufficient for diagnosing celiac disease? Which is like one of my favorite questions, because even among gastroenterologists, you may not get the same answer. So I'll give you sort of the brief update on that. In the US, really, and in pediatrics mainly, to get the diagnosis, to be really certain you're getting the diagnosis, it is a tissue-based diagnosis. So endoscopy, biopsy, I see the changes under the microscope, and the blood work was just done for screening. In more recent years in Europe, they've come out with guidelines saying that if your TTG is over 10 times the upper limit of normal, and you have a second test showing a different antibody, the endomysial antibody as being positive, then you can assume the diagnosis. And obviously looking for response in those numbers once going gluten-free. So in the US, I would say many of us are sort of starting to adopt that. And this is literally only if your TTG is over 100, which is plenty.
Oh, her video cut out. I don't know where she went, but we're going to pick it back up. There's a few similar questions that I'm going to jump on. So one along the line of diagnosis is from Jessica. So how often, or nope, where did it go? Oh, I remember she wants to be tested for celiac, but doesn't want to go back on gluten. So as we mentioned, in order to get a proper diagnosis, you need to be eating gluten. You do not want to be eating gluten. Other things that we can kind of look at. Again, would it be a technical diagnosis? That's something to discuss with your doctor based on other factors. But for diagnosis, there's kind of 4 things. Blood test, which Dr. Dankner was just discussing. Endoscopy, which is the gold standard. Genetic testing, which tells us if you have the ability to have gluten, or ability to get celiac, if it's even possible. And symptoms. So do you have symptoms? Do they improve on a gluten-free diet? That kind of stuff. You're back. I see you. I have to unmute you. Can you unmute yourself?
I can. I'm so
Okay.
Sorry.
Technical
issues. I apologize. Technical issues. So I think I was talking about
Diagnosis.
Yes. So we are more, I would say, allowing in these very certain cases with these enormously elevated TTGs, sort of the assumption, because there's virtually nothing else, I would say, that would give you a TTG over 100. I do like to repeat it again and just be sure that there wasn't a mix up in the lab or something crazy, or, they accidentally put 100 instead of 10. So I do recommend repeating it at that point with some of the other markers and really being sure that that's what we're dealing with.
Yeah. And I was discussing when you were gone, people that don't want to do a gluten challenge, kind of our 4 options for diagnosis: blood, endoscopy, genetic, and symptoms, which all give us clues to diagnosis. Do you want to kind of explain how you work with patients if they don't want to do the challenge with our options for genetic and symptom management or symptoms?
Yeah, it's really hard. I mean, it's a lifelong diagnosis, and it's very difficult if someone is already gluten-free to sort of get there, because you should be on this gluten-containing diet to have appropriate antibodies and serology testing, or else it doesn't really mean anything. So it would be useful if someone is really truly gluten-free, wondering if they have celiac disease at that point, to do the celiac genes. And only if you get a negative can you really know, like, I don't have celiac disease, right? It doesn't mean that you don't have a gluten sensitivity. I mean, there's many other things going on. You can have non-celiac gluten sensitivity. You can have IBS, you know, and gluten is, you know, a common sort of issue in like the FODMAPs anyway. So if you can't do the gluten challenge, I would say in that particular scenario, the celiac gene testing, I would recommend it. And it's not a complicated gene test. So it's not like you need to go to a geneticist or anything. They run these at commercial labs, LabCorp, Quest. Like, these are things that any doctor can order. Obviously, you want a gastroenterologist, preferably interpreting it. But honestly, even if you call the lab after you get your report, because there's like 20 pages of numbers and it's very confusing, often I call to sort of confirm what exactly I'm looking at. There is someone in the lab who can help explain it to you. And again, it's only useful if it's totally negative, then you could sort of put that aside. If it's positive, you go by the other factors.
Yeah. I see two more questions and then we'll kind of wrap things up. So one is, seems like there's a lot more women than men with celiac. Yes, we know that statistically. We can also just tell by our group. With that said, kind of questions of like, is there resources specifically for us? What I will say that I have noticed the biggest difference with men versus women when treating celiac. The similar piece is the rules are the same. The game is the same, right? What you need to do in terms of avoiding gluten, avoiding cross contact, what foods are safe, what food isn't safe, all of that is the same whether you're a man or woman. The difference is more around the psychological piece. I think both men and women handle it a little bit differently. Also, psychological piece is impacted by the age of diagnosis. So children versus an adult versus someone in their high school years has an impact on it. So I would say, you know, what we see with our clients is men and women have both struggles with celiac in terms of accepting it socially. It's just a little bit different for men and women, And so that's something that we work a lot with our clients on, and why we work so one-on-one instead of just like, here's information. While we do have that as an option, is there's different challenges. For example, you know, one is it's a lot of times men struggle more to speak up and to ask questions, and maybe more likely to eat gluten just to not have to be a bothersome at restaurants, you know, or that kind of thing. So that's just one example. Again, there's women who feel the same way, but more of that social, psychological aspect is different.
I'm going through the chats here and just responding to some of the other medical questions that weren't answered. And obviously, I'll preface by saying, like, you know, these aren't sort of end all advice. Obviously, you need to speak with your doctor, but I'm happy to answer, you know, sort of across the country in whatever capacity I can.
Yeah. There was one that a lot of people have, which is there different severities of gluten-free? Which I'm going to preface how I've heard it asked too, and then I'll let you answer, Lauren.
Wait, say that again. Say that again. Are there different severities of celiac or?
Celiac, yeah.
Okay.
So a lot of people will say, and this is like, I've seen this in Facebook groups or people come to me to work and they say, but I have really bad celiac. I'm super sensitive, or my numbers were really bad at diagnosis, so I have severe, or they might be silent and they say I have mild celiac. In their minds, thinking that there's like a spectrum of celiac disease. What are your thoughts with that?
To me, it's like, it's a pregnancy test. It's a yes or a no. And it's a yes or a no. And yes, you might have varying degrees of damage at diagnosis, but if the diagnosis was made appropriately and there was sufficient damage to meet that threshold in the criteria, it's a yes or a no. And you might be more sensitive for other reasons, like you might also have IBS or some other stuff going on, but even if your numbers are worse early on, it doesn't mean that you're going to have worse outcomes or, worse sort of timeline for you to be healing in the gluten-free process.
Yeah. Yeah. I think that's important for people to understand. It's black and white. It's a yes or a no. Treatment is the same, whether your numbers were high or low or medium. We follow the same protocol, same rules, regardless of what your symptoms are. So there may be other factors that we manage, for other kinds of symptoms. Like we mentioned, if, you truly are gluten-free and are still having symptoms, kind of what we already discussed all in the presentation, it's time for us to look into other issues. Anything else you see in the chat that we need to address? They were able to
Someone's
get
asking about the dose of the lactate pill. Honestly, you can't, as far
overdose.
as I know, you can't overdose on it. So I would just go by what's on the box. We talked about this one. Recommending your food labels. Would you expect other food sensitivities to go away with healing from a strict gluten-free diet? Maybe. It depends. Often with gut healing, you may just also feel better. So that's a maybe. Am I accepting new patients? Yes. But I hope you live in New Jersey.
Yeah.
You're technically like 21 and under. I could stay on here all night and answer your questions. I would say I'm happy to sort of chat and take this offline. You can message me on my Instagram at Dr. Lauren Dankner, I think, at Dr.
Yeah.
Lauren Dankner.
And we'll be sharing your social media with our follow-up. So you guys will have access to her to reach out and chat, myself as well. Just keep in mind, for people that are not clients and patients, it's challenging for us to give medical advice through DMs. If you give us a little snippet of information, it's not medically appropriate for us to give medical treatment.
Not medical advice, just,
yeah. So
just some tips to get you sort of to where you might need to go. Obviously, we can't give medical advice legally if you're not our patient, but if we could sort of guide you to someone who can help you, that would be the goal.
Yes, so keep that in mind. But I think this was great. Again, we'll follow up with all resources if you guys have questions. We appreciate everyone from jumping on late on a Friday night. So thank you guys all.
Bye. Have a great night.
Bye, everyone. Have a good night.